Hello, my name is Nicholas Merritt and I'm a student in Indiana State University's Doctorate of Athletic Training program. I am a graduate assistant at Indiana State providing medical services primarily to the track and field and cross-country teams. Today, I'm going to speak about the process that I currently go through to evaluate a patient with a lower leg or ankle injury. Then, I will describe some steps I'm going to take to improve my clinical decision-making. Athletic training students sometimes ask me a method of performing an injury evaluation on a specific structure. And you may be wondering the same thought. What is your method? I utilize the HOPS method, HOPS. Mentally, this helps me set up the basic process for the evaluation in my mind so that every evaluation I perform is similar in structure. H standing for history, O for observation, P for palpation, and S for special tests. Let's say that the patient walks in to be evaluated. I'll make a mental note of their lower limb gait, limping, or favoring one side, if it's very obvious. First, I'll have the patient sit at the edge of the treatment table and ask them questions about their injury history. The first question I ask is, where does the injury hurt? I'll have them point with one finger to the exact location of pain. If they gesture to a wide area, I have them point to the area with the most pain. This gives me the ability to determine if the pain is localized or spread throughout the limb. Next, I ask, how did the injury happen? By asking this, I can determine the mechanism of injury, and that knowledge can lead to the possibility of explaining the exact injury that occurred. Asking the patient when the injury occurred can notify the clinician of acute or chronic injury and also provide a continuation of the injury timeline. The patient's pain level, measured through a verbal or numeric scale, is not necessarily helpful in the diagnosis of the injury, but it can be useful for determining the patient's pain tolerance and to track progress in future evaluations. After asking about the patient's pain, I ask, have you treated your pain up to this point, with medicine, ice, or stretching? This informs me on what the patient has been doing for their own injury, and then I see if those things have been making them feel better, or if there are any activities that make them feel worse. These questions, in conjunction with the mechanism of injury, can help lead the evaluation in determining differential diagnoses. Asking questions about the history of injury that is similar to one that they are currently experiencing, or previous injuries, can help determine if the current injury is a re-injury or if a recent injury indirectly caused the occurrence of the current injury. If previous injury did occur, was it formally diagnosed, or did the patient have anything that they did for it in the past? And did that treatment work? These methods could potentially be used to help treat the patient, especially if the patient saw positive effects. Asking the patient about any protective equipment or wearables used in sport can help direct the clinician more specifically in terms of the mechanism of injury and their plan on whether or not the injury was caused or protected using that equipment. Next, I'll see if the patient is too painful to touch, or if they could possibly do anything on their own. If not, then I'll decrease the pain through stimulation and or rest, ice, compression, elevation, or RICE, and then perform the evaluation later once the patient is less stimulated by their pain. Now we enter the observation phase. First, I'll examine the site for swelling, bruising, or discoloration, and have the patient stand up and walk and, if they can, note any gait abnormalities. When looking at the possible damage and areas to a structure, we'll want to notice if there are any bony, muscular, or soft tissue elements that are involved at the site of pain. Bony elements would include possible damage, stress fracture, or irritation. Muscular palpation could lead into a strain or irritation of the affected tissue. Muscle attachments at the bone could diagnose tendinitis or inflammation of specific structures. Soft tissue tenderness could lead the clinician to think a nervous or ligamentous issue is involved. Also, the patient could just be generally sore or tight from activity. You always want to palpate structures above and below the area of pain, looking for any referred pain or cause, tight muscles, causing pain at the insertion point, a ligamentous tear, etc. Looking for tender areas and using anatomical intuition to determine structures that could be irritated, impaired, or damaged is essential in the observation phase. I only measure range of motion with a goniometer if there's a noticeable deficit as compared bilaterally with visual inspection. If I don't notice a deficit, and neither does the patient, then I don't normally measure. When performing special tests, I only perform if the history and the objective measures point to performing specific tests, like tenderness over the anterior talofibular joint would lead me to perform an anterior drawer. I don't normally perform a multitude of special tests, only the ones that I suspect could help ruling in or out the injury that I have come to suspect from the patient's history and observation and palpation. If the patient is suspected to have a muscular injury based on palpation, manual muscle tests will be performed around the joint. For the ankle, I would test the tibialis anterior through dorsiflexion and inversion, the tibialis posterior through plantar flexion and inversion, the peroneus tertius and extensor hallucis longus and extensor digitorum longus through dorsiflexion and eversion, and the peroneus longus and brevis through plantar flexion and eversion. It is important while performing manual muscle tests to ask the patient where they feel the pain. During this test, it's important to rule in or out specific injuries to specific structures based on where the pain is occurring during the manual muscle test. If there's a possibility that the patient presents with non-serious injury and their palpation comes up negative, and there are no positive special tests, and the manual muscle tests come back full muscle strength, it's possible that the patient will want to practice. The clinician should conduct functional tests, such as a single leg hop, jogging, or the lower extremity functional test, which includes jogging, karaoke, side shuffles, and sprinting, and even a single leg balance. These functional tests should only be performed if there's the probability of the patient actually practicing that day, and if so, to determine if the patient is prepared to practice or perform their activity that is involved with their sport. At the conclusion of the evaluation, I'll tell the patient their diagnosis that I have come up with and possible differential diagnoses that could be related to their specific symptoms. I'm going to give a patient on the plan of what we're going to do that day and future steps to help them progress. I'm going to let them know their practicing status and what they can and cannot do that day and possibly days in the future. I'll ask the patient if they have any specific questions, and I want them to leave with a positive attitude about the direction that I will take for their injury treatment. There are always improvements that need to be made. After reviewing my clinical decision-making, I've determined 5 things that I need to do better. Number 1. Check for syndesmotic ankle sprain. Working with the track and field athletes, medial tibial stress syndrome is highly common, and sometimes I get telescoped in on specific pathologies. Tibial location of pain is not always muscular or bony, and could be related to the interosseous membrane. I need to utilize special tests, such as the mortise spring, to assist in ruling in this pathology, and not to get telescoped in on specific pathologies. Number 2. Measure range of motion with a goniometer no matter what. Range of motion is a clinically based outcome measure that is highly underutilized to help determine the patient's initial functional deficits and/or their rehabilitation progression. I should be utilizing range of motion to fuel my clinical decisions. It may not be directly related to helping me diagnose the injury, but measuring range of motion will help determine treatments and exercises needed to help the patient become more functional. I should be measuring this range of motion using a goniometer or a digital inclinometer, so I have actual measurements and numbers that I can utilize for continued progression. Number 3. utilize a patient-related outcome measure. I've been trying to integrate patient-related outcome measures more often into my clinical practice since I learned more about them this year. Patient-related outcome measures help with the history-taking process, and they also help build a base of knowledge that can later be used for determining if the patient is improving. Number 4. Asking the patient about their type of pain and determining neurovascular symptoms. I realize that I do not often ask the patient what type of pain they are feeling, or if they have any numbness or tingling. I would probably get some of this information from the patient when they describe their level of pain, but without prompting on the patient's questions, this may exclude some of this information. If the patient feels a dull ache or a sharp pain, these differentiations can help lead to separate diagnoses. Number 5. Be more cognizant of the patient's overall demeanor. I always need to remind myself that the patient is a person too. I can't just get hung up on the injury. Asking how the patient is feeling in terms of daily life, classes, and overall well-being helps the patients feel more confident that you actually care about them as people and not just a specific injury that needs to be treated. Thank you for taking the time to watch this presentation. If you're a clinician, I hope that you've had a chance to reflect on your own clinical decision-making for the ankle and lower leg injuries, and what changes you need to make in order to improve the overall care that you provide your patients.